Hello, hello, my dear friends. Hello.
Yes, sir. Yes, sir. We can see.
Okay, can you see this? You can see the polyposis, and
Yes, sir.
you can also see the little polypoidal inferior turbinate. So basically, this patient will be advised immunotherapy. The Ig is high. Pack. கொஞ்சம் இதா இருக்குல்ல அவுட் ஆஃப் ஃபோக்கஸா இருக்கா ஏன் okay. So this pack contains 1 in 1000 adrenaline. கொடு இன்னும் கொஞ்சம் கொடு அண்ணா கொஞ்சம் ஹைப்போடென்சிவ் கொடுங்கண்ணா அண்ணா அம்மா சார் இருக்காரா அண்ணா இன்னும் கொஞ்சம் கொடு பேக். ஹலோ.
Yes, sir.
Okay, I'm going to start the case now. You can see that this is the polyposis. Debrider. Debrider. So the first step is to luminize the airway. So how do we start? We have to keep it like this on the inferior turbinate and then move up and down. So we have basically 3 steps. The first step is called luminize. See, I've luminized the airway. So this is called luminization of airway. Second, from backwards you come. From backwards you come. The second is delineation of anatomical landmarks. So what are the landmarks which we have to delineate? The first landmark I want to delineate is the middle turbinate. So I have to see the middle turbinate. See, that's the middle turbinate. You can see one polyp medial to the middle turbinate. Just going to take off that polyp as well. So see that now beautifully the middle turbinate is fantastically delineated. Now the third landmark, sorry, the second landmark I have to delineate is the uncinate process. Okay, so that's the uncinate process. So that's it. So I got the axilla of the middle meatus. So what are the landmarks? Number one is the middle turbinate. Number two is the uncinate process. Number three is the axilla. So having done that now, so my suction. See, the blood will flow down into the oropharynx. Of course, give me a pack. Of course, my anesthetist has packed the throat pack, so it will not dribble into the airway. This way, I get more reservoir for that blood to collect. So you prevent what is called the choanal banking effort, coronal banking effect. Okay, so this is my step 2. First is luminization of airway, second is delineation of anatomical landmarks. Third is dissection of middle meatus. So dissection of middle meatus should be just like FES only. How you are doing for endoscopic sinus surgery, the same way you have to do for polyposis. So how are we going to do that? Okay, now give me a backbiter. So same way, like how we do with the backbiter, the same way you do. See here, I'm using a backbiter. ஏம்மா ஃபர்ஸ்ட் செட்லேருந்து எடுக்கல என்னம்மா இப்படி பண்ணுறீங்களேம்மா not a good backbiter. The backbiter I use is Jesco backbiter. This is a Bakwaska backbiter. Now see, you have to bite at the base of the Nix triangle. See, use in such cases where you have a lot of bleeding, don't worry. See, now I'm starting at 10 o'clock. See how fast we can finish this fest. It takes hardly 25 minutes per side. If you do
Sir,
it properly, it's just 25 minutes. So septum will take another 10 minutes. So 25 plus 25 is 50 plus 10. Exactly 1 hour, we can finish this whole case. Now, I'm doing it with demonstration also. See, all this I would not do packing and all. I'll just straight away go ahead and do. I want to show you the anatomical landmarks. That's why I'm doing this. Okay, here we are. Suction. Now we do what is called the hanging technique. What is the hanging technique? Give me ball probe. So these techniques I have devised. Don't tell this in exams if you're a postgraduate. So it's called the hanging technique, but it's very easy for us to understand what is the hanging technique. So here we are. That's the natural ostium. Ma rat 40 kuduma. So that's the horizontal part of the uncinate process. See, that's the horizontal. See, can you see? Beautifully seen. Wow, wow, wow. See that U-shaped. I'll just remove that. See, that is the horizontal part of the uncinate process. It has got two attachments, inferior attachments. One is the, see, that is the turbinate attachment, and that is the lacrimal attachment. See, beautifully, that U-shaped attachment. What a beauty. Now I'm going to start my dissection of the middle meatal antrostomy. See here, I go inside. Now you see, so this is the, so in such cases, it's better to do a type 3 middle meatal antrostomy. So what is the type 3? I'll show you what is the type 3. So basically, this surgery is not done only as a cure, it is done for good post-operative follow-up. So the steroids, all
to
that
reach nasopharyngeal space.
should reach that
Yes.
area. So type 3 means you go till the posterior wall. See, I'm going till the posterior wall. See that, I'm going right till the posterior wall. And then I'm opening up the, that's the infraorbital nerve. And sometimes what we also do is to take a little bit of the inferior turbinate as well, a part of the upper part of the inferior turbinate. So that finishes my maxilla. Beautiful view of the maxillary sinus. This is a basic case, not a very advanced case, but the basic case you should follow all the principles of surgery, or else it's going to be difficult for you to actually do a difficult case. This is a virgin case. More importantly, it's a virgin case. That means it's not been operated before. எவ்வளோ பேர் இருக்காங்க? Oh, house full, huh?
Ah, today house is full because the people are going prior to the basics to advance.
Okay. So this is the case we will do daily. Okay. Now the next step, what is the next step? So first step is MMA has been done. No, give me a RAD 40 itself. Now see here, this is the MMA which has been done. The next step is to take off the upper part of the uncinate process. See here. See here, this is step 2. Small perforation is there. See here. So don't take the uppermost part. Just leave a little bit. See, that's the
Sorry.
uppermost part of the uncinate. This is the aganazi which we saw. This is the aganazi, beautifully seen aganazi. This is the attachment of the uncinate process. So, beautiful view of the aganazi. So, what is the next step? The next step will be I've removed the uncinate process. That's the uncinate process. See, that's the upper attachment of the uncinate, vertical attachment of the uncinate. But the uppermost attachment I have not removed. Okay. Now give me a pack. So the second step is removal of the upper part of the uncinate process. Okay. Now straight, all straight debrider. Now what is the next step? Step number 3 is removal of the bulla. So bulla can be removed in 2 ways. One is the bulla up technique. Second is bulla, sorry, centrifugal technique, centripetal technique. So here I will show you in one side centripetal, another side centrifugal. Centripetal has been propagated by Professor Filippo. Now I'm just going to start my centrifugal technique in this case. See here what I do. There's a little polypodal middle turbinate. I don't want that. Okay. Now I start here. See, that's a centrifugal technique of the bulla. See how beautifully you can remove that bulla.
Always we have to identify the ethmomaxillary crest, sir.
Yeah, already identified, you know. You saw,
Yes.
no? The ethmomaxillary crest here.
Yes.
See, that's the ethmomaxillary crest.
Sir.
Debrider. Now, I'm just taking off the bulla alone. See here. So, don't take the upper part of the bulla. See, upper part of the uncinate is left behind. Upper part of the bulla is left behind. That is the suprabullar cell. Don't bother about it right now. You don't have to bother about it right now. See how beautifully the basal lamella is coming into view. That's the basal lamella. See that? How nicely the basal lamella is coming into view. See the upper part of the uncinate process. This is the upper part of the uncinate process. Don't worry about it. That will be a beautiful landmark for your frontal. Okay. So here we are. So that's the basal lamella. Complete basal. See, basal lamella is the coronal attachment of the middle turbinate, where the middle turbinate actually, see, if the middle turbinate goes and gets attached to the lamina papyracea. You understand? So this is the next step. I have beautifully removed the bulla. Okay. Now I'm just going to keep a small pack again. So after every step, you just keep a small pack so that you will orient yourself. Now I'm going to keep a pack and ask for a smaller pack. Why? Why? Because posterior ethmoid dissection for juniors, this is for juniors I'm showing you. I do that completely only with a gauze piece. So that's the easiest way to do a posterior ethmoid dissection. So here we are. See here.
Sir, good morning, sir.
Morning, boss. Who is it?
Sir, Krishnamurti, sir.
What?
Krishnamurti
Sir,
from
Krishnamurti.
Vishakhapatnam.
Oh, Krishnamurti, sir. Many of your voices are the same, boss, so I'm not able to recognize.
Sir, sorry, sir. Sir,
No problem, boss.
from
What
the
is sorry
beginner's
about
point
it?
of view, sir,
Ah,
from a beginner's point of view, so
oh,
do you recommend intact bulla for opening the frontal, or after a delineation of the skull base, then opening
Boss,
the
this
frontals.
all depends on how you have been taught, boss. See, I was taught by Professor Stamberger. Okay.
Okay, sir.
Stamberger never does bull-up. Professor
Okay,
Sethi
sir.
is a strong proponent of bull-up. It's all depending
Okay,
on the anterethmoidal artery. If you find that the anterethmoidal artery is dehiscent, then
okay,
do the bull-up. If it is
okay, sir.
not dehiscent, why you want to do bull-up? I mean, depends. Whatever you feel is easy you do. There's
Sir,
no
what
one
is
way.
one cell above technique, sir? What is one cell above?
Yeah, one cell above means you suppose you have the maxilla open the anterethmoid involvement. But this one, it's not like this is full house space. This is full house space.
Not in
What we
this
are
case.
doing here? Yeah, not in this case. This is full house. All the sinuses are involved. You can see how beautifully we are delineating the skull base.
Sir, what would be
And
your indication for nasalization of the sinuses, sir?
nasalization I do only when you find extensive fungus or recalcitrant sinusitis. All these I do nasalization.
The simple
So see,
osteitis also is one of the indications,
yeah,
sir.
that is MRSA. No, if you have
Okay, sir.
MRSA recalcitrant, it's called recalcitrant
Yes.
sinusitis.
Yes, sir. Yes, sir. Yes, sir.
Okay.
Okay.
See, I'll tell you one thing. If you are finding a cell directly with a 0-degree telescope, no,
Sir.
it
Okay, sir.
is very unlikely for it to be a sphenoid sinus. Just remember this. Many people think this is a sphenoid sinus and come out. It is very unlikely that you have opened the sphenoid sinus. If it is a direct visualization, it is very unlikely that you have opened. It's mostly a post-ethmoid or a onodi cell. Okay, remember that, very important. This is the lamina papracia. See, after every segment, I am packing with 1 in 1000 adrenaline. So this pack should never be used when you expose the dura. Be careful. If you do that, you might have some ischemia. Now, give me a debrider. Now you see how nicely the skull base has been delineated. And then I go for the superior meatal window. We do what is called the baby walk. I'll show you what is the baby walk and the Jula technique. Okay. Now, having done that, this could be a cell between the sphenoid sinus and the break a sleep, please, and the maxilla. Okay. Now give me a pack. Now I will go for the Jula technique and the baby walk. Okay. All these are packs soaked in adrenaline. Okay. Having done that, see, I've almost entered into the posterior ethmoid. The skull base has been delineated beautifully. Oh, okay. Now let me start the baby walk. Okay. Now see here, this is you start the baby walk from uh, the posterior end of the bulla. This is the bulla here. When I go there, 1, 2, 1, 2, 3. See, it goes inside, and then you sweep the. So that's the superior turbinate. See that I have opened up the superior meatal window. See how easy FES is. I mean, there's nothing at all in FES, provided you follow the anatomical principles. So that's the superior turbinate. My irrigate. See, not even once I have fogged my scope. Not even once I came out to anti-fog. Did you notice this? I always count the number of times my resident comes out to anti-fog. All these are important factors to say how experienced you are. If you are good, you will never come out even once for anti-fogging. So again, I opened the sphenoid sinus. I'm just keeping this back. See that? Now I'm going to remove that suction debrider, please. So see here, that's it. After this, you straight away open the sphenoid. Always in polyposis, it's better to marsupialize the sinuses. Marsupialization means open it as wide as possible. Minimum should be type 2. Good is type 3. Of course, in polyposis, you don't need to do a type 3 sphenoid. Debrider, please. Quick. No, pack. Now, Anna, hypotensive kudungana. What is the BP? Huh? So, I have now completed the maxilla, the ethmoid. I've gone till the sphenoid sinus. Okay, right. Now, what is the next? The next would be to go for the skull base. So, how do I go for the skull base? Now, I'm just going to just see the sphenoid sinus. That's the sphenoid sinus. This is the Parsons Ridge here. Blackesley, please. Here, open the sphenoid sinus so wide. You can see that so wide opening of the sphenoid sinus. Okay. Now, that's a maxilla. Debrider, please. Now, I'm going to start my irrigate. Irrigate. Now, I want to give me a forward mode. Forward mode, please. So I want to remove this Parsons Ridge. Ready? Irrigate. That was the first time I fogged. A beautiful way to open up the sphenoid sinus, and you just have to do all this to reduce the spicules. All forward mode. Okay. Now, having done that, now that's it. I've almost finished the posterior dissection. I've gone till the maxilla. I've opened up the sphenoid sinus. Now comes the last part, which is the frontal sinus. Give me a big pack. Okay, so that's it. So how do you do the frontal sinus dissection? It is simple, nothing big. No rocket science involved. Suction. Now I am going to use my 70-degree telescope. So as you see, I use my 0 and 70. That's all. I don't use anything else. So there are various ways to do frontal. You can do axillary flap. You can do whatever you want. But this is what I learned from late Professor Heinz Stamberger. So opening the egg, it's so easy. See here, this is, give me a suction now. So it's very simple. It's a wide frontal recess. I told you there's a lot of cells here. So I'm just, don't press your suction tip and open it. Just I want to see the uncinate process first. This is the uncinate process. Yeah, I can see that very clearly. This is the uncinate. And I found a type 3 cell also. This could be the type 3 cell. Give me a, no, ball probe. First you use a ball probe. See here. Now use the ball probe. You go between that type 3 cell here and the, see. Now this is how I open up. I know exactly where this ball probe is going. This is all after reading the scan. You should understand that. You should not go somewhere and open it. It could be a type 3 cell I opened, no problem. So I'm just going to debride that and get debrider, RAD 60 debrider blade. Now my instrument is below now. So very clear. See how I'm using my debrider blade. And I am sure that this is not the frontal. This is just the type 3 cell. So see, that's the type 3 cell. Very clearly seen type 3 cell. Okay. So once you have the type 3 cell like this, how do you open the frontal? This is very, very important. If you have a big type 3 cell, some people go through the cell. I strongly recommend you not to do that. I mean, at least when you want to teach, you should not do that. Okay, so that's the anterior model artery here. Here. That's the phobia here.
Just
That's
go
the type 3 cell.
behind the posterior wall of the type 3 cell.
Yeah, that's right. That's right. So see that, that's a type 3 cell. Now give me a ball probe again. So use the ball probe. Ball probe is the best instrument to open the, see, this is the type 3. I'm going behind the type 3 and I'm opening up. See, this is the behind the type 3 and I'm opening up. So that again we fogged. Second time fogged but that was because my instrument hit against my endoscope. So I opened up the type 3 cell. That's it, finished. What is the big deal? So if you read your scans properly, what is the big deal in opening all these cells? Block mother. Block, please. Give me a wash. Nicely blocked. Now, what you do is when your block is getting relieved, you can give a good wash.
So for a good
Okay,
frontal work, preoperative sagittal scans are very much important, sir.
nothing like that, boss. I never take sagittal. All these are teachings, boss. All these are teachings. All that when you become experienced will actually vanish. It is all depending on how well you reconstruct your coronals into sagittals. If you have the right mind, you can reconstruct all. Illama, giraffe ma, ennama, innuma tappu pandrema. You can reconstruct all these coronal scans into whatever you want. I can reconstruct a coronal scan into an axial scan into a debrider into a sagittal scan. So you don't need everything and all. Now you see here. Now you see how I'm changing to instrument above. This is instrument above. Now see, I'm opening up the frontal recess at the cost of the anterior fovea. I keep telling this to my residents. So the usual dia of a frontal recess is around 1 to 1.5 centimeter, not chumma. So this is the anterior model artery here. See, the anterior model artery, there's a fovea. Now see how nicely you open the frontal. Beautiful. Now give me a good wash. Okay, you have to keep giving washes. This is something very, 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 very important. If you don't wash, you might miss a lot of fungal debris. Again, I learned this from Professor Heinz Stamberger. See that? That is the frontal. This is the anterior ethmoidal artery here. Of course, not dehiscent, but you can see that very clearly. This is the fovea here. Okay, right. So what are the boundaries of the frontal recess? I can still further open the frontal recess wider. I'm going to do that, debrider. So the boundary medially is the middle turbinate, laterally is the lamina papricia, posteriorly is the anterior ethmoidal artery, this is the fovea, and that is the nasofrontal beak. So all the four boundaries should be clearly defined. Now the middle turbinate boundary alone, I have not opened properly. So I'm going to open that middle turbinate boundary. Just for beginners, be very careful here, because this is the thinnest part of the skull base. Now give me a giraffe now. Giraffe is one instrument you should have in all endoscopic procedures. See how that giraffe is going to take off this. Okay. See that? Wonderful. Now you see how nicely, debrider again, how nicely we have opened up the frontal. So this is actually the end of, okay, the nasofrontal beak. You see that? This is the fovea. This is the anterior ethmoidal artery. Be very careful when you do all these maneuvers as a junior. Of course, once you become experienced, all this will be just nothing. See how the spicules are being removed from the level of the fovea. Now you see how the frontal recess is open now. Can you all appreciate it, please?
Yes, sir.
So that's it. So now what I have to do is to see the skull base. So the skull base from the frontal should be what? Say straight கொடுறா கண்ணு straight பிளக்கஸ்லி எப்பவுமே straight தாண்டா கொடுக்கணும் கண்ணு. கொடு. Okay. Now I'm using a 70-degree telescope, and I'm going to show you the skull base. This starts from the nasofrontal beak here, very clearly seen. This is the frontal, the fovea, the anterior ethmoidal artery. This is the posterior fovea, and that's the planum. All that is beautifully delineated. Fantastic. A little bit of mucosa is deficient here, but that's okay. I mean, yeah, that's the ethmomaxillary crust. Now I'll put the 0-degree telescope and show you how the cavity looks like. And the last, you should always see the olfactory cleft. This is always you should do that. If you don't do that, you can have residue. So that sometimes when you do that, your olfaction in patients can be benefited. This is very, very important. Debrada, Debrada, please. Straight dama kodukunu. Now I'm going to visualize my, why is the, okay, right. Now I'm just going to visualize the olfactory cleft. See that the olfactory cleft, that's the remnant superior turbinate. Okay, I'm just going to see the cleft. Okay, that's fine. Now I'll just reposition the middle turbinate. Looks just beautiful. I'm very happy with the final result. Okay, now give me a wash. So if you see here, I told you I took around 10 minutes extra. I started at 10, but 30 minutes. Definitely for demonstration, 10 minutes is allowed. Now see, this is a complete full house fez. I don't know if that is going to be a small polyp. Give me a debrider. But be very careful, because that can lead to a little bleeding. So you should have a little bit of ovulation here. Okay. Okay. Don't destabilize the middle turbinate through biting. I don't want a spicule like this to be hanging. See how nice the cavity looks. Looks like a bay watch appearance. It's called the bay watch appearance. It looks like a lady draped just in a thin satin cloth. See here. Ah. Suction, please. I'm just going to put suction and show you. This is the maxillary sinus, very clearly seen. This is the nasopharynx, clearly seen. This is the sphenoid sinus, clearly seen. I'll take off this spicule. Then this is the lamina papracia, clearly seen here, draped with mucosa. That's the skull base, and of course, that's the frontal, clearly seen. So it's a single cavity without any sort of stalactites or stalagmites. So that's the end of one side of S. I'm going to start the other side, but this side you have a problem. What is the problem? The problem is the patient has a septal deviation. Give me an infiltration. So this will take another 10 minutes for me to correct the deviation. As I told you, this is more of a maxillary crest, which is actually deviated. Knife. Now I'm going to start. What? What is your question? I don't understand your question. Elevator? So I'm using a Cortels elevator here. Today is Shilpee's birthday.
Wow, happy birthday, madam. And many, many returns of the day, madam.
Actually,
God bless you, madam.
I'm giving her a very nice case to operate. That's my treat for her on her
So,
birthday.
wow.
She's going to do the next beautiful case. Okay, this is the Royal Pearl technique. I have published this also. The problem with most of the Indians are they're all good, but the thing is they don't publish. I also failed to publish many of my techniques. So when it comes later, I feel a little bad. Mm, mm. Okay, elevator. See how nicely a septum can be. It's like a painting. Now, what do we do actually in a case like this? So you should understand that what is the purpose for this septal correction? Understand what is the purpose for this septal correction? Is it for nasal obstruction? No.
To prevent Bernoulli effect.
No. It is
Oh,
actually for good post-operative follow-up.
yes.
So these patients, if you have to visualize the middle meatus post-operatively, then you necessarily have to, suction it and do all that. So the thing is, do as less as possible in such cases. Don't be aggressive about the septum. You don't
Okay.
need to be aggressive. Just do as less. Don't, and only when the patient is coming for nasal obstruction in a scissors, in a case, then only you have to do a aggressive septal correction. You should understand that very clearly. What is the purpose of that surgery? I know one resident who was here, he from a very leading college. So there were lymph nodes in the neck. So I asked him to take, it could be Cori lymphoma, Cori something they had put. And I asked him to take a biopsy. He was doing something like a radical neck dissection. Scissors. So we should understand the purpose of the surgery. Okay. So here I'm not taking off too much. I'm just concentrating on the inferior part of the septum. You see here, tuck tuck. Have it like that. Have it like that. Tuck tuck. No, I'm just going for the where alla. மேல தூக்கி. Ready? Tuck tuck அடி. Tuck tuck. இருமா விடுமா. புடி இப்படி புடி. Tuck tuck please. இரு வர. அடி. ம் ம் அடி அடி. அவ்வளோதான் முடிஞ்சு போச்சு. So having done that, I am just trying to take off this tuck tuck. Avalada, that's it. Now having done that, now you see how nicely this is going to come out now. Elevator. This is the philosophy of this our technique. So no creation of some tunnel, this tunnel, that tunnel. Take it off, take it off, take it off. Okay, finished. So I'm just going to take this out now. So you see, that's the spur which I was talking about. The maxillary crest is here. It was attached to the maxillary crest rather, the bone. Now you see that? That is it, finished. Now, can I visualize the frontal? No. So I need a little bit more. So what will I do here? Will I actually take off that upper part of the septum? I wouldn't like to do that. Blackously, please. See, I have not torn it at all. That's the biggest plus point you would have seen here. Now in this technique, we have got some techniques where we don't tear any of the flaps. That's the biggest advantage. On the IDA recording of frontal my first frontal, because I have to post that in a group called the World ENT. My first recording of the frontal way back with an IDA. Where are scissors? Thick scissors. So I need to do this because if I have to do a proper frontal, then I have to, that's a septal body, right? Okay, right. I just made a cut. I'm not interested in taking it out. See now? Beautiful now. See, I can see everything here. Okay, give me a pack now. That's it. So I took around 10 minutes, as I told you, for the septum. Okay, I'll take some for biopsy from that side, the other side. Hello? Anybody
Sir,
watching? Why is it so silent today?
98 people are watching, sir.
Why so silent today?
Because it's special day, sir. So we should be silent.
Special day. What is special about this day? What is special, boss?
Sir, Madam birthday, sir. We should be
My
silent, sir.
was Singh sir's birthday, sir.
Madam
Madam,
birthday. Pavi.
she is
Nageshwar
not
Rao Garu.
speaking. She is not speaking. Let us not speak.
Hey, call Shilpee, man.
Sure, sir.
Hey, caller. Ma, biopsy எடுத்துக்கோமா. Hey, septa biopsy அமிச்சிராதம்மா. Hey, Shilpee, where are you? Hmm. Now, the problem again is that, see, that's the septum here. This is the inferior turbinate, elevator. Now, I want to increase the airway. And for that, what I will do is to move this inferior turbinate away. Anna, what is the BP now? Na? Increase பண்ணிட்டீங்களா? Shilpee, back. Hey, what is happening? What is the other case going on? I mean, is she working on that case or? அப்படியா முடிஞ்சா இல்லையா முடிஞ்சா இல்லையாண்ணா Now I'm going to start the side. Again, it's the same principle. Debrada. See how the septum is. Now here, I might keep the debrider towards the septum. Block, 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 block. Instead of keeping it towards the inferior turbinate, block suction work. Now see what I do here. So the first step again is the same. This is actually a flap of the corblated.
Sir, will a transfixion suture here prevent Bernoulli, sir?
No, boss. The problem with the Bernoulli is not the suture. It is because there is no septum.
Okay.
Don't worry, we can avoid the Bernoulli. See how I'm doing that. This is called using the debrider as the fulcrum. So I've gone to step 2 now, delineation of anatomical. The middle turbinate. Okay. Now that's the Ansonet process. Back. I've seen many people using punch, Blecksley, so many instruments for FES. We never use only one single instrument, that is debrider. If you have a proper IPC console with a good debrider M5 handpiece, this is like driving a Mercedes Benz. You should have a good camera, and I strongly recommend the Spice camera, not even the, what is that? I don't like the 4K camera. Bakwas. I like the Spice camera. That's why even if it's old, I go for that model. I don't like any other company because they don't give true color manifestations. Of course, now innovative tech is good. Now, where is Shilpee? Get Shilpee here. Now I'm going to do the hanging technique. Ball pro, please. Why is it bleeding like this? Suction. Okay. Now I'll do the hanging technique here, the same like what I did the other side. Ma, call Shilpee, ma. Shilpee, you're been wished by Dr. Nageshwar Rao Garu. Did you hear? Rat 40. Just go there and say thanks. Go. Go to the this one. Ma, இது
Happy birthday.
change பண்ணு. So
We have spent 10 years.
Happy birthday, madam.
Some 1 decade. Big achievement. It's from Marxism. Of it. Not something. Hello? Hello? Yeah, you asked madam.
Thank you, sir. Thank you so much.
Happy birthday, ma'am.
Thank you, everyone. Thank you so much.
Happy birthday, madam.
Thank you. Thank
All
you.
the best.
Thank you.
Happy birthday, madam, and many returns of the day. God bless you.
Thank you, sir. Thank you so much.
Thank you.
okay, now you can change to the picture here. Little bleeding is too much on this side. I don't know what is the BP. Preeti, BP எவ்வளோமா? ஏம்மா bleed ஆகுது? So what I'm doing right now is I'm just packing the nose in with 1 in 1000. Many people use Merosil for packing. I'm not sure if it is great because it doesn't apply the pressure. Give me a coblation. It doesn't apply that pressure which is required to stop bleeding. மா தண்ணி கொடுமா. Now I'm going to start. I've done my first step, which is actually the middle metal antrostomy here. Rat 40, please. Now the first step is to do a type 3 osteotomy. Middle metal antrostomy should be type 3. Ma block, ma. Debreda block, please. I don't know why. What is happening? Wow, 15 minutes. I should finish this and go. Ma, next case intubate, ma. Fess on the fess circle.
What is the next case, sir?
No, that's not demonstrated, boss. All the other cases are not demonstrated.
Okay, right.
Yeah. Well, just one case I thought I'll demonstrate.
Sir.
Kuduma. And this is a basic case. Anyway, you wanted some basic cases, so I'm demonstrating a basic case. So how do you deal with this turbinate? See, basically, what I will do is I will start the patient post-operatively on immunotherapy. So here, I am not at all happy with an osteotomy like this, ostium like this. Why? Because I have to do a type 3 ostium. See what I do now. It's going to be a mega antrostomy. Very, very important, my dear friends. And the first step is to get the ethmomaxillary crest, which is here. This is the ethmomaxillary crest. You get my point? So this is the first step. So I'm going posterior till the level of the posterior part of the, that's the horizontal part of the Uncinate process. You can bite everything with the debrider. Some say the debrider blade will get nothing like that, boss. So now, see, I'm doing a different technique for the bulla. It's not the usual technique which I do. This is what is called the centripetal technique. It's not the centrifugal technique. You see, this is the bulla here. This is the middle turbinate here. I'm going towards lamina papracia. People don't advocate going towards lamina papracia. They go infero-medial, but I'm going laterally. See, this is like following a arrow. The lamina papracia is the arrow for me. And this is what Professor Filippo, Alexander Filippo, my very, very, very close friend, that's the retromaxillary cell. So he propagated this technique. Just get all these ethmoidal cells out. So this side, the anti-ethmoidal artery is a little dehiscent. Now you see this whole bulla, you see that it's intact now. I can remove the bulla in one piece. So this is what I told you, suction, straight debrider. So this is the centripetal technique. If you have an inverted papilloma attached here, you can remove that in one piece, suction. So this is called the centripetal technique of dissection of ethmoid. Very, very important to know both the techniques. In one technique, you go infromedial to the bulla. See, that's the bulla, complete bulla. This is what you should have done, right? No, I didn't do that. I went towards the lamina papracia. Now that's the basal lamella. See that? That's the basal lamella. Now, on the other side, I showed you the gauze piece technique. Irrigation. Here, I'm not going to show you the gauze piece technique. It is just with the debrider which I'm going to remove. Again, you need a little experience. Don't follow me blindly. It's not the right thing to do. You should be slow and cautious when you are in your first 100 pest cases, because you can enter the skull base or you can damage the optic nerve. So that's the skull base now, very beautifully seen. So this is a raw confidence with which I'm doing. That's purely because of the number of cases we have done. I request the juniors not to do this. See, I'm running my debrider over the optic nerve. So the left side I showed for the beginner, and this is the right side being showed for the experienced surgeon. Now see, everything is like a flow. I didn't use the baby walk technique, nothing. Just I went. I'm now getting the superior meatal window. That's the superior turbinate. I know there's an onodi cell here. See, I didn't come out with the debrider at all. Single stroke, like in a billiard snooker, I play snooker. Single shot, you finish the whole table like that. With one debrider, you go inside. If it doesn't get blocked, finish, kalas. No packing, nothing, straight. That's why I said you have to go by anatomy. So see here. Now this is again the sphenoid sinus. I just kept a gauze piece because there was a little bleeding. Always anterior wall of sphenoid is a little vascular. So we generally keep a little bit of that. Ma, you have to coblate, okay? This is Patuko. I don't want the turbinate to. So that is the sphenoid sinus. I know. Debrider. Now I'm just going to open and connect the sphenoid with the onodi. See, that's the sphenoid sinus. Beautifully seen. Ma, ஏமா block ஆயிட்டே இருக்கு? Are you holding it or something? இல்லையே, block ஆகுதே. Now give me a forward mode quickly. Don't do anything. Just give me the debrider. Now that's the sphenoid sinus. I can see that very clearly. That's the sphenoid. And that's the onode cell. And that's the skull base. You can see the skull base, skull base, skull base, skull base. Already delineated skull base. On this side, you can see a little bit of the, see that's the sphenoid sinus. I'm going to use the forward mode. Forward mode, please. So that I use for the Parsons Ridge very often. Debrider. See how we are able to change between the, what is the advantage of this forward mode? Debrider. It preserves mucosa at the same time cuts the, what is happening? Now you see that's the sphenoid sinus which is completely open here. See how wide the sphenoid has been opened. That's over the optic nerve. Enama, any problem? What are you talking? அந்த சைடா அது நேற்று ஒன்றும் பிரச்சனை இல்லை. We have a very nice case of a tumor that will be done tomorrow, right? Or whenever battery comes. I'm leaving to Dubai tomorrow. Yeah, tomorrow is Friday, right? Oh, oh, day after. Okay. Ma, idutama. Give me a forward mode, please. Ready? Irrigate.
Sir, what is that cell, sir, which you're opening now?
Harzala. The Harzala cell.
Okay.
Retromaxillary cell.
Okay.
So, whenever you, that's the commonest site of residual cell. That's what I think the study by Harzala. Nice friend of mine, Harzala. Nice guy. He's from Egypt. Action, please. Now I have completed the posterior dissection completely. Now, what is the posterior dissection? That's the sphenoid sinus here. Hey, you have to remove this man later. Manasi will remove this. Lamina papricia, skull base, skull base, skull base. Now we'll go for the frontal. Coblation. Now give me a 70-degree telescope. Okay, here we are. I'm going to start my frontal dissection. See here, there's a 70-degree telescope. RAD 60, please. Now it's very easy. Just use your RAD 60. Now I'm not doing my conventional like the beginners. This is a little advanced. Don't follow it unless you have done more than 100 test cases. See how I open. They're all, after little experience, you get to know this. See here. Now, hey, debrider ma. First, what you do is get the Ansonet process. See here. Okay, that's the Ansonet process. See, I know exactly where my debrider pointing. Don't do this unless you're experienced. Again and again I say this. This is a type 3 cell. So I'm going automatically behind the type 3 cell. Everything is done with the debrider. No, nothing is being used apart from the debrider. Again, caution, don't do this unless you're experienced. Irrigate. So this side you saw the anterior model artery being dehiscent. I'm going to show you the anterior model artery. See, over. Frontal is over. Just see, it took hardly a half 30 seconds for us to do. So when you want to do like a beginner, see that's the frontal, very clearly seen. Give me a good wash. You have to go use the ball probe, then J-curette, then if you want to do a gauze piece technique, all that you follow when you're not experienced. But if you are super experienced, then, but you should understand that there is a study which says that complications come only after the 100th case. You know that? There is a study. Manasi, do you know that? No, this is first. Complication comes only after the 100th K. You understand? See, that's the anterior model artery here. You can see that clearly here. That's it. So be very careful when you're doing your 100th case and beyond. Okay. All right. That's it. So I have done the frontal very nicely, but there is still a cell there. So no. Give me a this one. See, this is a cell. So I know exactly what is happening there just by reading the scan. See here, this is actually a small party wall. See, this party wall you should recognize. See how experienced you should be to recognize that party wall. Understand? Or else you would have left that, and that could have caused osteitis, and that can cause frontal sinus stenosis. Get my point, Manasi? இதெல்லாம் தான் பார்க்கணும். இந்த இதை if you have not removed, then I will think that you are not yet there. Dip right.
So that is suprabular frontal cell, sir?
No. That is a part of the uncinate process.
Uncinate process, sir?
That's a part of the uncinate which was attached to the middle turbinate. That was read by me in the scan. Amma block ஆயிடுச்சுமா. So you see here, that's the interfrontal cell. You can see here. So this demonstration I need. I need the person to show me the interfrontal cell, or else I would think that he is not yet there again. See here, this is the interfrontal cell, and that is see. Can you see? Interfrontal cell, anterior model artery, frontal sinus. Can you see both? Yes or no? Hello, my dear friends. See how beautiful you can
Yes,
see
sir,
the
sir.
Yes, sir.
interfrontal cell and the frontal sinus. See here. Again, I show you, it's a picture perfect. See that? Beautiful. Right. Now give me a 0 degree. Almost finished.
Medial one is interfrontal cell, sir?
Medial is, yeah, interfrontal. 0 degree, please. So you have completed the surgery. Started at 10 o'clock. Now the time is 11 o'clock. And debrider. So the last thing you have to see is the olfactory cleft. All these are checklists. You should always maintain the checklist, or else you will miss something. Irrigate. Yeah, irrigate, dear. Bernoulli acting. This is a skull base. Beautifully seen skull base. Okay, right. Now you have to remove this, Shilpee, Manasi. This you have to remove. Now I'm going to the olfactory cleft. Okay. I think it's fine. I'm going to bulgarize this. That's bulgarization. Part of the superior turbinate. Okay, that's it. Finished. So this spicular bone you have to remove, okay? Use a rat 40. So you saw that FES can be made so fast and easy as well as very, oh sorry, system, I'm really sorry, Professor. Yeah. So I hope you enjoyed the surgical demo. It's a basic case, but it will be useful for postgraduates. Okay, so any doubt you have?
The CT, sir, so that we can see the upper end of the
Post-op
unspecific.
follow-up, you just speak a word, sir. Post-op follow-up.
Post-op follow-up, in this case, I'm going to give immunotherapy.
Sir.
I will start the patient on immunotherapy and then I'll give steroids.
Sir.
I'll be giving 60 milligrams starting and then I'll reduce it to around 10 milligram, 5 milligrams, stop it over a period of 10 days. And I'll give steroid sprays for 2 years. I'll douche with, if the same thing is recalcitrant, I'll use Manuka honey. In Dubai, it's available as a spray. Manuka honey
Wow.
spray now it's available. Yeah. So, whereas in India, you have to go to the Amazon.
Yes.
So when I come from Dubai, I just buy this spray and come back so that I can give my patients.
What is the cost, sir, on each spray?
Boss, that is in dirhams, boss. I don't know. You have to ask
Okay.
Syed. Syed is here, huh? Syed is here. I don't know if he's here. Okay. So Manuka honey spray is very good. I mean, continue it till you have a stabilized cavity. So that's how there is no limit for any post-operative follow-up. Like you have to keep doing it till you get a good, healthy cavity. That's very important.
Sir.
And then, of course, what else? I think we have done with most of the.
So what about immunotherapy, sir?
Yeah, immunotherapy. I get it from. No, I get it from this
what will
guy,
you give?
the Ashim Desai.
Cup
Just
chips.
you contact Ashim Desai. He has a fantastic experience and he has got a kit also, beautiful kit. I get it from him only. Every day nowadays we are doing some 10 cases.
Omalizumab molecule is there.
Huh?
Omalizumab molecule is there, no, sir?
Omalizumab doesn't help much, boss. You can put dupilumab. Dupilumab is Dupir, Dupixent. That is very good, but it's very expensive, no? People say that it's available in black market here. I don't know. You have to ask. Okay. So, okay. Have a nice day. Bye-bye.
Thank you, dear.
Put some comments in the group, boss. How basic